Here is a service evaluation at our hospital trust looking at preoperative lung function testing. Are we testing the right patients, and do those tests actually change outcomes? Pre-op lung function tests incur a financial and capacity cost to our trust, and there is no agreed local pathway defining which patients should undergo testing. In the literature, there's no robust evidence linking lung function tests to post-op respiratory outcomes, and NICE reflects this in its guidance that patients should only be considered for testing if they are ASA 3 to 4 with known or suspected respiratory disease and having intermediate or major surgery. The AAGBI calls us to action in its recommendations, supporting protocolised referral pathways written by senior anaesthetists. So that was our starting point. We reviewed all preoperative lung function tests performed over 5 months across one pre-assessment pathway, and this gave us 48 patients to look at. We found 2/3 of referrals came from the surgical teams, and in fact 34% of patients had already had their tests before arriving at POA assessment. Here you can see that more patients had a respiratory comorbidity in the group that displayed a moderate or severely abnormal test result, but that this same group had a lower proportion of post-op respiratory complications. You might think that a possible reason for this is the tailored anaesthetic plan put in place for patients with poor results, but in fact only 3 of our patients had a change in either their risk discussion or management plan resulting from their lung function testing. So what does this tell us? Well, if a patient has respiratory disease, they're more likely to have poor test results. But we already know this, so do we really need the test? We don't observe any impact on outcome in this sample, and lung function test results are guiding management in only 6% of our patients. So, how do we standardise testing in a way that is useful? We surveyed anaesthetic consultants at our trust and found that 92% favoured a combined threshold of both unstable respiratory disease with some form of poor functional status. 70% also supported empowering the wider MDT to initiate referrals. We retrospectively applied this proposed pathway to our cohort and found 11 of the original 48 patients would have undergone testing. Based on local tariffs, that equates to an estimated annual saving of between £16,000 and £39,000 at a single site, of which we have 3. So our findings suggest that our preoperative lung function testing is often driven more by fear of delay than by clinical indication and infrequently changes management. A standardised pathway could reduce unnecessary testing, provide clarity for the MDT, and improve resource utilisation. We're excited to develop this project further with next steps expanding across our trust and nationally.